triglycerides and all, when they tend to become higher, how do we deal about it? Is there any special way, I would say, or there's a better way to deal with such patients? So these are my disclosure slides, in fact. So now coming to our first topic, so we all will agree, like even in we are in almost in November 2022, which is coming towards an end. We already have seen a pandemic as well. We do come across lot of other diseases as well, which has been causing significant mortality, morbidity as well. Although even now, cardiovascular disease does remain to like a leading cause of death, not just in UK but even on an overall basis in the Europe as well. Even on a global basis, if you'll try to have a look, so there are almost 320 million life years which are lost on a global basis, causing around 17.6 million deaths. In UK alone, if we'll try to talk, almost 0.17 million deaths happens, and 47,000 of them is nearly premature deaths. And just by looking at the statistics, this is literally overwhelming, isn't it? And especially during the pandemic as well, there has been a huge percentage, or even number wise as well, death, which has been attributed to the cardiovascular disease as well. So why is it that lipid profile is so important? Is it just to diagnose a patient, or to label them as dyslipidemia? Is it just to label them as the cholesterol levels are abnormal? So we are aware that there are different measurements are done. So different measurements is like, someone may agree that we tend to call it as a non-HDL cholesterol level. Which we everyone will agree, like this is the equation which we typically tend to calculate it indirectly as well. And there may be fewer labs which will be even asking what about the other markers like apolipoprotein B, or even the triglycerides alone as well, or the other markers. However, with the growing knowledge, more and more research has been coming up which has been emphasizing the role of other cholesterol components, and our understanding has been becoming better and better, so that these other markers also have a significant part to play in the atherogenesis, and which finally leads to the coronary artery disease and even other complications like the stroke and other complications which we all will be coming across. So most oftenly, even the guidelines, they are very vocal about the LDL cholesterol targets. We tend to emphasize on LDL cholesterol, low density lipocholesterol targets are very important. There are various risk scores as well, which we even tend to emphasize. So, for example, there is a score risk, or Q risk as well, which we tend to typically use in our day to day life, on the basis of which, if the score is less than one, we call it as low risk, or moderate risk is the one having a 1 to 4%, or the high risk are the ones having around 5 to 9%. And these are the ones which even will be associated with the moderate CKD, or even diabetes mellitus without any organ damage. So these are the patients which tend to have a pretty high risk. And even last but not the least, there's also another category, according to cardiovascular risk category, of very high risk, where the risk is more than 10%. So there, the ASCVD has already been established either clinically or even using the imaging modalities. There may be a family history with a major risk factor, or otherwise even the EGFR tends to be pretty low, in fact lower than 30 ml per minute, or they tend to be diabetic with a target organ damage. So, for example, more than or equal to three major risk factors. So these risk factors has been done in association with the European Society of Cardiology. I did. I have been part of some of the clinical groups as well, and whenever these meetings tends to go, it's not like just looking at one parameter. It's not just about looking at one treatment and all. We need to be able to assess what about the other risk factors? And it's not just about trying to target or controlling the levels of a component like a LDL cholesterol, maybe the triglycerides, but what about the cardiovascular morbidity benefits, the mortality benefits as well? And this is what we try to think. So yes, in our day-to-day life, we tend to emphasize like, okay, LDL cholesterol, we need to target on that, we need to control about that. But a lot of times, there is also residual cardiovascular risk. So, for example, you are targeting the HSCRP, you know, to take care of the inflammation reduction. Similarly, for the lipoprotein A risk as well, so we try to start on some of the medications and all, which will be taking care of the values. Similarly, the diabetes as well. We understand some of the commonly used medications is like the SGLT2 inhibitors, GLP-1 agonists, and all. But what about the residual cardiovascular risk? Even if we have been trying to treat these patients. So, on an overall basis, we tend to define the residual CV risk as the residual risk of incident vascular events or progression of established vascular damage, which tends to persist in the patients treated with the current standard evidence based therapies. And I must say that the identification and treatment of the residual cardiovascular risk is nothing less than critical if we want to optimize the patient outcomes and also reduce the risk for recurrent events. So, if we look carefully at this slide, we can look carefully at what happens is this is a group of different patients who have had myocardial infarction, ischemic heart disease, or ischemic stroke as well from the Copenhagen City Heart Study and Copenhagen General Population Study. If there is a higher risk or higher value of the triglycerides, there is a proportionate higher rise in the hazard ratio for myocardial infarction, for the ischemic heart disease, and also for the ischemic stroke as well. So, what about the triglycerides? In 21st century, the kind of medicine what we practice is evidence-based medicine. It's not just about like, okay, someone is saying, so do it. Someone is not saying, don't do it. So if there's a medicine, a proof for that, if there is a evidence which suits to the clinical profile of the patient, it needs to be implemented. So there was a very interesting post hoc analysis of nearly 3,700 patients from the PROVE ITTMI trial, which survived having an event free of like almost a month. And what they noticed, so there was a huge number. So as we shared, in fact, so this was a group of patients who were admitted with acute coronary syndrome with total cholesterol of 240 milligram per deciliter or 200 milligram per deciliter if they were receiving a lipid lowering therapy, and they were randomly assigned to lipid lowering therapy and versus the to receive the intensive therapy, which was atorvastatin 80 milligram, or the standard therapy of pravastatin 40 milligrams for a mean follow-up of 2 years. If we look carefully over here, then we can clearly notice the difference. If the triglyceride levels are controlled, the event rates will be definitely much lower, and it seems to be quite a lot significant. And okay, and later on as well, reduce IT trial has been a very interesting study in the sense like it had some of the really good inclusion criterias, like they tried to include about statin treated men and women which were aged more than 45 years who were already established cardiovascular disease, or even diabetes mellitus plus minus one risk factor of like if the triglycerides are elevated, if it is more than 150, or even at the LDL cholesterol if it is more than 40, or similarly, so they were randomized, in continuation with the statin therapy for that, and they were randomized. So as we can see it over here, the two groups was one was a group of like 4,000 patients who received placebo treatment, and the other group was the one. So I try to take it, say it in a simple way. 2 grams twice daily. Okay, so there is no confusion. So they receive the icosapent ethyl, okay, icosapent ethyl, and they were followed up at regular intervals, and there were primary endpoints, and of course there were secondary endpoints and the MACE. So there was a 5-point MACE, major adverse cardiac effects, which were defined as the 5-point composite of non-fatal MI, the non-fatal stroke, or even the cardiovascular death or hospitalization for the unstable angina or the coronary revascularization. Okay, so when these patients were followed up, as you can see over there, for a long, long time, it's not just about like 6 months, 1 year, 2 year, 3 years. So they were really followed long time. And when we try to look at the patients with an event, we can definitely see that the patients who were on placebo compared with the icosapent ethyl, it was a significant difference. And as we can see over here, the p-value was 0.0000, a lot of O's over there. Okay, so I don't want to make it too complex. So we can definitely see the cumulative event of which was the composite of cardiovascular death, the non-fatal myocardial infarction, or the non-fatal stroke, or the revascularization, and all was pretty low for those which were on the icosapent ethyl. Similarly, the secondary endpoint, which was the 3-point MACE, which included the non-fatal MI, non-fatal stroke, or the cardiovascular death as well, again, it was significantly low for the patients who were there on the icosapent ethyl. And of course, those patients were followed up as well for a long, long time. So this is something like a forest plot, which makes it quite a lot easier for us to be able to understand. So what it shows is the rates of all individual and composite ischemic events, except death from any cause, they were significantly lower in the patients who were on Vazkepa group. Okay, that's the commercial name for icosapent ethyl. When we try to compare it versus the placebo, including the rate of the cardiovascular death as well. So this is a very interesting, as we can see, these all of them are favoring the Vazkepa, in fact, right? So we all are very curious people, isn't it? What about the other events? What had happened? What about the primary composite endpoint events as well? So even over here, when we try to have a look, as we had already said, they tend to definitely go in mostly in favor of the Vazkepa, I would say, on an overall basis. So we must be clinicians. We must behave responsibly as clinicians, as a healthcare professional. So there's nothing called as which doesn't have an adverse reaction. So yes, there are some side effects as well, which is also associated with this medication as well, which we can see it. So there are something called as what is called as system organ class, MedDrug 1, or there's some adverse reactions. But if we'll try to look over here, that most of the side effects has been quite a lot uncommon, or there were some of them like the gastrointestinal side effects like the constipation or the eructation, or even sometimes the subcutaneous disorders and all. However, they were easily manageable. Although some of the common problems which we all come across, which whenever we go or meet our colleagues, that what about the side effects like bleeding, which was seen in 11.8%, and even the atrial fibrillation, which is around 5.8%. I'm a board certified electrophysiologist, so I did my EP training from Maastricht, and even in the expert consensus document on AF ablation, my 2 papers are referred. So this was definitely something which is close to my heart, and I always try to consider what about the patients? Is it really going to increase the atrial fibrillation risk? So if you will try to go through the data, having a closer look, we noticed like Vazkepa patients were the one who was having around 5.8% versus 4.5% for the placebo. And in fact, the atrial fibrillation of the flutter patients which required hospitalization was quite a lot low. I would say like almost 3% for the Vazkepa versus the 2% for the placebo. And when we try to further look or go back in the history, that what about those patients? How about the frequency and all? And is it statistically significant? It was not, as I said it. So in fact the increase as well, which had been there for the atrial fibrillation episodes, it was not so significant, and most of them had been manageable. And coming to the other side effect, which was about the bleeding. So yes, serious bleeding events were reported more frequently in the patients receiving Vazkepa than in the ones who were receiving a placebo when administered in combination with their concomitant antithrombotic medication. However, percentage wise, because it was a huge patient group which we all saw, so 3.4% for the Vazkepa group, and the 2.6% for the placebo group. Although it occurred at the same rate, so which was around 0.2% for the subjects who were not taking any concomitant anticoagulation or even antiplatelet drugs as well. So that is another very interesting insight. Uh, I'm sure, I think a lot of people may agree that if someone has had used the fish oil and all, so there were some sporadic case reports of increased chances of bleeding tendency and all as well, which seems to be happening even over here, which is attributed to the possible antiplatelet effects of the group, in fact. So, icosapentanoic acid may have beneficial effects on the multiple atherosclerotic process. You know, so icosapent ethyl, although Vazkepa, which is a stable ethyl ester of the omega-3 fatty acids, icosapentanoic acid. So it is a stable ethyl ester of the variant, in fact, okay? And the mechanism of action contributing to the reduction of the cardiovascular events with the icosapentanoid, we are still trying to understand, but some of those things are not really very much clear. Although what we can see over here, definitely, it appears like a multifactorial reason, like an anti-inflammatory, antioxidant, in fact, a reduction of the macrophage accumulation, or even the improved endothelial function as well, which may be adding to the benefit of the cardiovascular risk profile whenever these patients are initiated on the Vazkepa. So, how is the effect of the omega 3 fatty acids on the cardiovascular outcomes? So, if we look at this again, forest plot, it is quite a lot clear that, again, it is favoring the omega 3 fatty acids, isn't it? When we try to compare with the control over here. And Evaporate has been another interesting uh, trial, in the sense like it is a randomized double-blind placebo-controlled trial of statin-treated patients with established stable coronary artery disease and elevated triglycerides. Again, the patients were randomized to icosapent ethyl, which was around 2 grams per day, versus the placebo, and then they tried to follow them up at different time intervals, that how did they meet the primary endpoint versus the secondary endpoint parameters as well. So the good part of this study was they really tried to look at the imaging. So they try to use these images as well, like how can we use the imaging to diagnose, is it a coronary artery disease, how is it progressing, how about the CT coronary angiogram as well. So if we look over here really carefully, it tends to also give a little bit indication towards the mechanism of action of the icosapent ethyl. So the baselines coronary computerized CT coronary angiogram. This is a CT coronary angiogram in a 54-year-old male with a history of diabetes, hypertension, and hyperlipidemia. So when they receive the optimal statin therapy, okay, and later on, when they tried these patients were followed up on multiple parameters. So, like the calcification, the fibrofatty deposition, the fibrous or the low attenuation plaques, or the total non calcified plaques, or even total plaque burden as well. We can definitely notice over here they all tend to favor is Vazkepa. Are there any queries so far? Or otherwise, we can take them at the end as well. Is it okay? Yeah. Oh, right. Um, just to make a little bit more interesting. So, for example, to share clinical case as well. So, what we can see in front of our screen is he's Mr. Paul. He's a 60-year-old a person with type 2 diabetes mellitus who is admitted to the hospital nearly 3 days back with ST elevation myocardial infarction. He did undergo a primary PCI with two stents placed with a normal LV ejection fraction of like almost 65%. Other than diabetes, which was diagnosed nearly 4 years ago on metformin only pre admission, he has no other significant post medical history. His GP told him his cholesterol was high and was advised to change his diet. He does work as a financial advisor. He's married with two children. He's a non smoker and drinks 8 to 10 units of alcohol per week. So his BMI is around 29, not too high, I would say. With family history of cardiovascular disease, in the sense like his father did have a myocardial infarction in his 50s. Does this picture sound a little bit familiar to our audience? So this guy as well, it's a typical thing is like, cholesterol was little bit high, okay, just take care of the diet and all. However, when we look at over here, if we look carefully at these different figures, total cholesterol was 4.9, okay. However, the triglyceride was 4.5. The lipoprotein A as well is 70. So this is where a lot of times we may start to think, like, okay, this guy is already on some of the pretty good medications. Empagliflozin is there, ramipril is there, atorvastatin, and all. So what I mean to say is, we do sometimes tend to ignore the triglycerides, and that is where the problems tends to happen. And this is what was tried to be attempted, I would say, to address for such group of patients, that in the reduce IT trial as well, which we were talking. So they were the different inclusion criteria was again typically like this. Those patients who are aged more than 45 with established cardiovascular disease, or even aged 50 years with diabetes mellitus, or more than one of the additional risk factors, or the primary prevention cohort with a fasting triglyceride level of 1.52 moles going up to 5.63 millimoles as well. Or similarly, the LDL cholesterol, if it is 1 up to 2.6 millimoles per liter, and with a stable dose of statin, at least for more than 4 weeks. There were several patients excluded in this study as well, which included like severe heart failure patients, or the active liver disease if it was deranged, or if the glycosylated hemoglobin was pretty high, if there was a history of pancreatitis, acute or chronic, or similarly, of course, if they were hypersensitive to fish or shellfish or any of those seafood components and all as well. So, if even when we try to reflect on such kind of patients, what we already saw that multiple benefits had been seen for such patients. It was not just about the benefit of the unstable angina, the ischemic stroke, or even the myocardial infarction. So it did was able to help, or a good majority of our patients, as we saw through the p values as well. So this was pretty important. So now coming towards the end, if we would like to summarize, yes, there's no doubt about it is we should not ignore serum triglyceride levels which are elevated, and definitely they are a serious risk marker for any kind of cardiovascular disease as well. And we did see some of the clinical studies. One of the major ones was Reduce IT trial, in which when they tried to use at least 2 gram twice daily, to be precise, it was like a 998 milligrams. So again, 2 2 milligrams, which was short of a gram. So on top of statins, if it is used with those patients with high triglycerides, and even if controlled LDL cholesterol, with a established uh, with established cardiovascular disease or uh, is everything okay, Ravi? I can hear you. So what it means is, yes, now we are able to understand. Hello, hello. Yeah, yeah, yeah. I can hear. I'm so sorry. Oh, so sorry. Okay, so I'll go through the summary again. Apologies for that. So, to what I was telling is, um, now there's no doubt about it. Is we all understand that there is a increased or big role of triglycerides as a risk marker, even in the cardiovascular disease, due to the process of atherogenosis and also causing multiple cardiovascular disease, the other manifestations as well, which we all can see. Similarly, about the dosage, again, it is, to be precise, it is not 1 gram, I would say. So it is exactly like 998 milligrams. So again, the two. So that's why I said it in the easy way is like 2 gram twice daily. And again, if you try to be precise, it is 2 milligrams less in each dosage as well. So if you try to use, which was shown by the Reduce IT trial, on patients with elevated triglycerides and control LDL cholesterol, even either with established CVD or diabetes or even additional risk factors, there was significant clinically meaningful reduction in the MACE, uh, which includes major adverse cardiac events, which was pretty significant as well for such patients. And yeah, in the Evaporate study as well, we were able to see, using the imaging studies, that there was a reduction in the atherosclerotic plaque reduction and also the stabilization of the plaque as well, which is also similarly key to reduce the MACE. And Vazkepa is indeed approved by the NICE several months ago. It had already been approved by the US FDA as well in US since several years. And in the CE, it had the CE approval. So earlier I was working in Netherlands, so I do remember they had been using it since earlier times. So there's a very detailed, nice guidance about like what are the suitable patients and all, which we can see it over here, and we already went through as well. So if there will be any further questions, I'll be more than happy to answer. Thank you so much for your patient hearing. Yeah, please. So, to tell you interestingly, just few days back, there was another study, prominent study, which was presented at American Heart Association. Okay, So uh, it was again re-emphasized. I'm not telling this is for the first time. So earlier as well, multiple clinical studies has been there which showed that lowering triglycerides using fibrates, even with low LDL and all, is not useful. So prominent efficacy study as well, again, emphasize the same findings. So as I said, it's not just about to be able to control the levels of the value, like okay, is it in the normal range or not? But what about the morbidity benefits? What about the mortality benefits? And that's what is the key nowadays to for a good clinical treatment, I would say, okay, for the patient. So, considering that fibrates are no longer advocated, I would say, and that's why there's, I know a lot of my colleagues as well, they tend to avoid fibrates for such kind of patients. And as I said, it even the latest study was prominent study, which was presented like maybe just 2 days back at even at American Heart Association meeting as well, tends to confirm the same findings that fibrates, no, for such patients. Yes. So it does feel like four tablets. Yes, it is there. So it's like two capsules twice daily. That's what, as I said, this is how I try to share it with them, and most of them, I must say as well, there has been several clinical studies in which they said it up to 60% of the elderly patient, which may be even higher in some of the areas, they already tend to take supplements. And you may be surprised if you may ask them like, oh, are you taking omega-3 fatty acids or the fish oil as supplement? It is a pretty good uh, you may be pretty high on that side. So a lot of people are tend to be comfortable taking fish oil supplements. So if you just say it like this, like this, there is a so we try to say it like this in simple words. It's a highly purified form of fish oil, up to 96% purified, which is enriched in its unique constituent, which we already said it. So, which tends to cause the significant benefit for this. So, that is where lies the source of comfort for a patient as well who has to take it. So they will be quite a lot comfortable taking a highly purified form of fish oil. Yes, of course. I wouldn't advise that. So, for example, it's not a good idea because when we are trying to think for the therapeutic levels, that's what we are all are interested in. So, as I say, it's not just about starting something. Okay, we are trying to give them mortality benefits. We are trying to give them morbidity benefits as well. We are not just trying to control the numbers. We're trying to give them these benefits. And so I wouldn't advise why to give someone a impure or you know impure form when there's a pure form which is already available. I hope it makes sense. Of course. Sure, sure, sure. I think see, I'm pretty impressed by your deep insights and intriguing questions. So, see, we need to have more smart doctors like you, I would say. Yeah. I wouldn't say that. Yeah, please. There's nothing like that. So, as if you will try to have a look over here as well in this table, this is beautifully summarized about the different side effects and all. So, sometimes, yes, peripheral edema, or even gout and all, you can just monitor them on a routine basis. So there's nothing like there are. I'm sure you all will remember there are some medications for which we need to do routine tests. So, for example, like dronidron was another brother of amiodarone for which we advise liver function test must be done. So far for Vazkepa, there's nothing like this. But yes, we just need to monitor them symptoms wise as well. So and these symptoms has been most of them quite a lot easily manageable. Yeah. That's another good question. Thank you for asking that. There's nothing like that up titration or down titration in Vascepa. I'm not aware of that. So, what the formulary says is initiating them on 2 grams BD twice daily, and we tend to monitor. So, most of them, I would say, in my limited experience, which I have used on the patients, it has been pretty good. So, I did not like come down or go up on the dosage and all. No. Thank you so much. Thank you so much. It was really nice interacting with you all. Have a wonderful day.